Uh, I hope you can hear me and see me all right, because I can't see anyone at your end. So I'm not seeing any flags. So thank you very much for inviting me to this afternoon. I apologize I can't be with you. I've had a recent infectious disease and didn't want to share it with you, but I will share the presentation. So there are a number of references I have here, and rather than putting them individually on the slides, I've just collated my sources, but I will speak to them as we go along. So here are our casts for today. We've got measles morbillivirus, we've got the gram-negative diplococcus, meningococcus, and we've got a fleet of vaccines that can assist us with these disorders. So we're looking at new and existing threats, and this is an enormous topic, and we're looking at it both in the global and the Australian context. And the two key features are the top two on the slide: increasing incidence of the diseases and decreasing immunization rates, and that's what I'll focus on in this session. A number of other factors which we will all be familiar with regarding vaccine access, vaccine hesitancy, what I refer to as vaccine ennui, just fed up and bored with vaccines, and going right down to the socio-environmental factors and the social media. In fact, I learned a new term called echo chambers, that if you get into social media which doesn't support immunization, you may find yourself getting shrouded by more and more of social media sites which disagree with vaccination. So, and of course, we may be just missing out on what's going on in regard to the diseases and the vaccines. So where should we focus our efforts? And I wonder, who are we? Well, it's us here this afternoon, and the group gathered, but it's also our populations, our communities, our healthcare practitioners, our politicians. All of us are involved in responding to the threats posed by the increasing incidence of measles and invasive meningococcal disease, both in Australia and worldwide. So looking at how to address this, where should we focus our efforts? Again, that's a very broad question, and I don't have an answer. I put together this jigsaw puzzle, and it's really an attempt to symbolize that it involves all of us, involves all Australians across many domains. So education, health promotion, funding, and I put funding twice because I think that's pretty important, and looking at the production and distribution of vaccines, and then looking at what's happening in our communities, so surveillance and research in terms of what's going to be happening in 5 years or 10 years, and what contingencies do we have in place for that. So just some very broad ideas. And then I learned that yesterday the National Immunisation Strategy was released, and I realised that a lot of my session this afternoon is probably going to be redundant because it's all in here. And I understand that was released with the Public Health Association of Australia meeting yesterday, so and I'm afraid I wasn't there for that either. But interestingly, I did a control F through that, and I couldn't find much on meningococcal B vaccination, which will be interesting when you see later in my session. And this is what I picked. I like picking out from a 50-page document a single page that summarizes everything, and this is it. And it's not for us to read and go through, but it does show a structure, so a strategic plan around approaching vaccine preventable diseases within the Australian context. I was trying to think, as a GP, what can I do? What does one GP do? What does a group of GPs do? What do pharmacists do? I can't comment on maternal and child health nurses. I can't comment on infectious diseases physicians. That's not my role. But I was trying to think, what could I do? And it's really more of the same. It's what we should be doing, but doing more of it and doing better. So particularly around identifying, so we've got targeting populations who are under immunized or overdue for immunization, looking at opportunistic vaccination, so we prioritize immunization in our consultations, and working together as primary care healthcare providers, so working with pharmacies, working with our primary health networks, so pharmacists working with GPs, GPs working with pharmacists, all to the benefit of our communities. And I did want to put in a quick plug that the immunisation consultation is a lot more than the needle, and I think that's an important point for all of us who provide, that it's there's a more going on to that, and we won't have time to go into that right now. Now, going on to the diseases. So I'm going to look at measles first. So just a snapshot. So I've tried to condense an entire textbook onto one slide. I'm picking up some of the key features about measles so that we know what we're dealing with. And the key features about measles are a prolonged incubation period and a great capacity for infecting other people. So infectious from about 4 days until 4 days after the onset of the rash, and secondary cases of about between 14 and 18. So very infectious, stays around in the air for a couple of hours, close contact not needed, so highly infectious. The clinical features during that prodromal phase, it's conjunctivitis, coryza, and cough, the 3 C's, and fever, and the Koplik spots, which we'll show briefly. And then a rash, which characteristically spreads from head down to toe, and then goes the other way as it wears off, lasting for about a week or so. So I don't think it's necessary to discuss the treatment of it. We're more interested in the prevention of it, but it's a disease which has complications. So pneumonia, encephalitis, SSPE, subacute sclerosing panencephalitis, is exceptionally rare, but it's invariably fatal, and possibly has a higher incidence in infants under the age of 1. And immune amnesia. So this is a phenomenon where children in particular may be, their immune system may be suppressed for up to 2 years after they've had a measles episode, and therefore increases their risk of other secondary complications. So those are Koplik spots. I've never seen them, and that's another issue, that many medical practitioners coming through have never seen anyone with measles and may not be familiar with it, and therefore less alert to recognizing it. This is the characteristic maculopapular rash, which over the first 3 or 4 days coalesces to form these sort of blotches and patches, purpley red black patches. That's a typical measles rash. And that's just to fool us, because that's not measles, that's German measles, but it's an indicator of how difficult it can be in clinical practice to make the clinical diagnosis. So, snapshot of measles. What about a snapshot of invasive meningococcal disease? Well, in contrast to measles, a much shorter incubation period and much less infectious. So the R number is between 1.2 and 1.4. The bacteria are short-lived, and close contact is needed for transmission. Clinical features, very variable, and that's again what makes it difficult to recognize in primary care, because the symptoms can be very non-specific and very variable, but very rapid in their progression. So maybe about half of the presentations of invasive meningococcal disease will be with meningitis. The classical symptoms are the fever, the neck stiffness, the vomiting, and the headache, with drowsiness or irritability. And perhaps about a third present with a septicemic illness. So that may be the fever, the petechial becoming purpuric rash, and septic shock. So the key in general practice registrars are always asking me, how do I recognize meningococcal disease in general practice? Because in general practice, it's different to what they see in the hospital. And the answer is suspicion, and having a low threshold for making the diagnosis, and recognizing the sick patient. So prompt intervention is essential, and early recognition aids that. So morbidity is high. About 1 in 5 people who get an invasive meningococcal disease will have complications, neurological or possibly limb and skin related, and high mortality of about 1 in 10. And this is what we don't want to see, because this is an infant with a widespread purpuric rash, so probably at a more advanced stage of septic shock. There's a bit of a jump. This is to set up the context for the end of this session, which is actually to do with costing. And I had to look these up. I wasn't aware of these prices, but this is roughly what the costs are of the vaccines that we use to help prevent meningococcal disease and measles. And I'm going to put in a quick plug. One of my other roles is in medical defense, and unfortunately, in medical defense, we do have many notifications through medical practitioners, so I don't know what's happening with pharmacy or with child health nurses, but certainly in general practice, that things are not done as they should be done. So incorrect vaccines given to the incorrect people, the incorrect timing, previous records not checked. So I just want to put in a plug for the using a framework for safety, such as the 6 R's, the 6 rights framework. So I'm now going to refer to the annual immunisation coverage report from NSEERS, and this has been referenced in the National Immunisation Strategy. So going to look at 6 slides in fairly rapid succession, looking at vaccination coverage across all children, and then looking at on-time vaccination, and then looking specifically at meningococcal ACWY vaccination. So first of all, this is fully vaccinated coverage, and what we're really I'm wanting you to look at, please, is just the bar on the right of each, the red bar, and compare that with what's happening with the bar on the left, the yellow, and things are stepping down. Our coverage for all children is dropping at all of the age markers. So at 12 months, 24 months, and at 5 years of age. So, and at 5 years of age, we're down to 92.7%. So this relates to all vaccines. So something's not going well. And this is with Aboriginal and Torres Strait Islander children, and the same patterns are there, but the figures are generally lower. If we look now at, and for this, for the context here of measles, we look only at the MMR vaccine, so that's the red line, and we can see that there's a dropping off on the on-time vaccinations for the first dose of MMR over the last 5 years. And again, the second chart for MMR, this is for the Aboriginal and Torres Strait Islander children, and again we can see a tailing off of the on-time vaccination for that first dose of MMR vaccine. Now looking at adolescents and meningococcal ACWY vaccine, and here we go again. If we look at the purple bar on the right of the chart, we're down to 71% of all adolescents getting their meningococcal ACWY vaccine, and the same for Aboriginal adolescents, and the figures there are even lower, so down to 61.1% of Aboriginal and Torres Strait Islander adolescents getting their meningococcal ACWY vaccine by the time they turn 17. So we're not doing well. Vaccine, unfortunately, it seems that our vaccine uptake is dropping, and particularly so in our Aboriginal and Torres Strait Islander population. So now going to move specifically on to invasive meningococcal disease, and this is looking at Australia. And what we can see here is that we're, over the last 4 years, we're seeing an increase in the number of cases of invasive meningococcal disease. So where is that going? We don't know. We can analyze that. What serogroups are causing these invasive meningococcal cases. Again, this is in Australia, and you can see there's a predominance of red on the chart, and this is B. But interestingly, if you look round the middle of the chart, so in the 2015 to 2019 range, you'll see that there's an increased proportion of the IMD cases being caused by Y in that's in the beige color, and in W. But that seems to have tailed off, and I wonder why that is. Looking now at more specifically at those serogroups, and as indicated on the previous slide, we can see that in those years from 2015 to 2020, Y and W were on a resurgence, but have now tailed off. But B remains the predominant serogroup in Australia, currently at about 83%. So I thought I would jump across the Indian Ocean and have a look at the meningitis belt. That's the sort of sub-Saharan Africa. And interesting there, historically, 90% of IMD in the meningitis belt have been due to serogroup A. And the most recent reliable data that I could find, which was the MEN-AfriNet data, quoted an annual incidence of about 7.5 per 100,000 population, at which time the highest incidences were C and W. And that's because in 2010, a very successful program of vaccination with a MEN-A vaccine, MEN-AfriVac, was introduced. So now that A is rare, however, there is now more of serogroup X, which has not occurred in Australia. B is extremely rare. Unlike in Australia, where it's the most common serogroup, B is extremely rare in Africa. And there is a 5-valent, a pentavalent vaccine, which is being rolled out, starting in Nigeria, started this year, last year, to deal with the increasing incidence of serogroup X. Both vaccines are temperature stable, and that's important for being in the African community. So now moving to the United States, and we're almost there. So invasive meningococcal disease, we said over that last sort of 4 years, has been increasing in incidence in Australia, and here it is the same as happening in the United States of America. And what has been shown in the United States of America is that they have an increased, a relatively increased incidence of serogroup Y, and that this seems to be associated with a higher case fatality rate than the other serogroups. So that adds further concern. Going to move now to measles, so bouncing back to Australia, and there we go. Just as we said, last sort of 4 or 5 years, we've seen an increase in the incidence of cases, and that's exactly what's happened here as well. If I now look more at the measles cases, looking at the 5-year age groups, the most recent data we have is for this year, and that's the red bar. And as well as showing that we have got a total increase in the incidence of measles in Australia, it does show that we're now getting more in the sort of the Gen Z age groups, the age 20 to sort of 29. Whereas when I said earlier with the snapshot of measles, we were saying that it was really an illness of younger children under the age of 5. So something's going on there as well. Going now from Australia off to the US, and measles used to be a very, very high incidence disease. Back in the 1990s, 30,000 cases per year, and then vaccinations were introduced, and it all but disappeared. In fact, in Australia, measles was declared eliminated in Australia by the World Health Organization some 11 years ago. So we are eliminated. Of course, we still get measles because it comes in from overseas. but there is the risk that it could go further than that. And again, just using a sort of a different scale on the y-axis to show that what Australia is experiencing is also happening in the United States of America, increasing incidence of measles. And there we go. This is sort of almost up to the date, 1,168 cases so far in the United States. And interestingly, we note that unvaccinated or unknown vaccination status in 95% of those cases of measles. And there also have been 2 deaths from measles in the United States this year. So looking now, going from Australia to the United States, now the global, and we look that yes, this has been shown worldwide that that measles incidence is increasing, and we haven't got data from last year or this year yet. This is World Health Organization data, but it is notable that in 2023 there were 107,500 deaths from measles, mostly under the age of 5. That puts things in context. Now, very quickly before we finish, I want to highlight something I think is quite important I believe it's important in responding to the theme of this talk, and that's the South Australia State Meningococcal B immunisation programme, and it's great that we're gathering in Adelaide to talk about this. So this was introduced in October of 2018 for children and then extended for adolescents at the start of the following year with a budget of $5.3 million per year. So 3 doses of meningococcal, and it's Bexsero because that's the only vaccine that's now available in Australia for meningococcal B. So 2, 4 and 12 months and 2 doses 8 weeks apart in adolescents. And what I'm going to show quite quickly is for children, adolescents and the overall population, what has been seen in terms of the reduction in the incidence of meningococcal disease over that period. So overall, if we look at the blue line, that's South Australia, and we compare that with the red line, and I think the curves tell the story. And that's similar for infants, so this is for the less than 1-year-olds, and similar for adolescents. So there has been a marked reduction in the incidence of meningococcal B disease in South Australia since the introduction of the program back in 2018. So meningococcal B, we're saying that's the most important serogroup in Australia, 83% on last year's data. So who else gets it? Well, Queensland, they've introduced a program too back last year, and the Northern Territory introduced a program at the start of this year. Under the National Immunisation Programme, so that's all states and territories, all Aboriginal and Torres Strait Islander children will get a meningococcal B vaccine, but not the Aboriginal and Torres Strait Islander adolescents. So who else gets meningococcal B vaccine? Yes, the medically at-risk persons, and there's no upper age limit for this. So again, the primary series will depend on the age at first dose, with a single booster 5 years after the primary series, except for the younger ones, then 3 years after the primary series. And the meningococcal ACWY vaccine. So this applies to all states and territories under the National Immunisation Programme. So children get a single dose at 12 months. Adolescents will get a single dose at year 10 or between the ages of 14 and 19. And medically at-risk individuals will get a course, and they get regular booster doses at every 5 years, unlike the meningococcal B. And measles vaccination, that's the same. So 12 months of age and 18 months of age as recommended by the National Immunisation Programme. There is catch-up for young people up to the age of 20. The recommendation is that if you were born in 1966 or later and do not have 2 documented doses of measles, then you should have a measles vaccine. That is funded in some jurisdictions, but not all. And it's also recommended for those who are at occupational risk, so healthcare workers, institutional service workers as well, or you can organise it yourself. And that's why I looked at what the cost would be. So you're probably looking at about $30 for an MMR vaccine if you don't qualify under the NIP. Medically at-risk conditions, so essentially immunocompromised, and the immunocompromised can be a problem for inadvertent vaccine avoidance. That if medical practitioners, pharmacists, maternal and child health nurses aren't sure if a patient is immunocompromised, they may not give the vaccine. So the big vision, it's nice to finish just on a vision. So the World Health Organization has set a roadmap to defeating meningitis, and has given us 5 years to do that. But I thought that was a nice thought to sort of end the session on, that we can think positively about what steps we should take. Good goals, now we've got to work out how to do it, how to get there. So thank you. It's a bit of a quick run through. There's a lot for me to cover, a big topic, and I'd be very grateful for any comments or questions, please.
Thanks very much for that great tour. It's lovely when you get diseases and going Australia and global. I've got a couple of questions online, which I'll just start with. I will hold some over for the panel, but we'll just go with a couple of specific ones. So one question is, are pentavalent meningococcal vaccines, the ACWYB, on the horizon for use in teens in Australia?
I think that's a fabulous question, and the answer is I don't know. What I am, and I'm sure that the panel will help me with this. I do know that it's probably more important that it's in Africa at the moment because they've got X. But I'm sure in future, I would expect in future, it will have to come Australia's way. So I'm not a very good answer, but maybe we can talk that on the panel.
My understanding is that there's a pentavalent being developed in the USA. Most of us are sceptical that that will reach any further in the process for the next 4 years, but we think it might be 5 to 10 years before it comes out. But there are a couple in the pipeline. So Rod Pearce here, just answering that for you. Thanks.
Thanks, Rod.
Also, actually, why is there a higher risk of meningococcal disease in sub-Saharan Africa?
Question, I don't know. Why, if there's a geographic or environmental or population, I mean, I think Robert Boy was referring to sort of nutritional issues and infection. I don't know. Good question. Don't know, does anybody else have any? Perhaps that's one for our panel.
Rod's not going to go for that one.
I want to ask him a question.
Go on then, you can ask him a different question then.
Yeah,
we'll look that one up and take it on
Rod
notice.
Pearce here again. Sorry, I wanted to ask a question about the old Wakefield autism and measles, and the fact that we're still talking about this after it's been disproved, and the whole environment of misinformation and disinformation and the echo chambers you're talking about. So any comments or feelings or ideas on here we go again and how do we deal with it and how not to get fatigued at the same old stories and the...
Yeah, that's a really good question, Rod. And I haven't got any answers, and I don't know if any other experts would have answers on. I believe we keep going with what we're going. We keep doing what we're doing rather than giving up, and we just keep working at it as the more challenges come along. I know that the issue. I think the echo chambers are a really good what's the word, metaphor to use for what happens in social media, and it makes it. We can't break into that, but I think presenting facts in a way that's empathic, respects people's different points of views, and enables them to make a better decision. I think that's the most we can do.